Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with previous lecture series, today we'll be discussing on one of the another interesting topic in compressive neuropathy, that is now compressed in some of the parts of the body. We call compressive neuropathy, and one of that which is most commonly present and you can see in your everyday practice very common is carpal tunnel syndrome. So we'll be discussing mainly on carpal tunnel syndrome in this lecture. Also, in general we call that as an entrapment neuropathy or compressive neuropathy. Now compression syndromes. So there are good number of now compression syndromes which are there. In upper limb, you will come across carpal tunnel syndrome, the most common, which is compression at the wrist. There is a pronator teres syndrome, which is again a compression of a median nerve, which is little higher up in a pronator teres muscle. Then there is cubital tunnel syndrome, where ulnar nerve is compressed. Then there is a ulnar tunnel syndrome. These are in upper limb. I've already uploaded one video lecture on thoracic outlet syndrome. You can go through that, where you get a compression of a brachial plexus. Bell's palsy also I have uploaded, that is the compression of the seventh cranial nerve or facial nerve in facial canal. Cervical radiculopathy is another very common which we come across in our everyday practice, that is a compression of cervical nerves. There is one another which is there in a upper limb, that is suprascapular neuropathy, which is a compression of a suprascapular nerve. Long thoracic nerve can be also involved. So that is called long thoracic nerve palsy or long thoracic nerve compression. So carpal tunnel, pronator teres, cubital tunnel, ulnar tunnel. Ideally, we can consider also thoracic outlet syndrome, which will be part and parcel symptom signs in upper limb only. Cervical radiculopathy, suprascapular neuropathy, long thoracic nerve. These are all upper limb, related to upper limb. Only Bell's palsy will be related to cranial nerve. Radial tunnel syndrome, then posterior intraosseous syndrome, short form called as a PIN, which is again a radial nerve. Now this is lower limb, ilioinguinal neuropathy, superficial peroneal nerve neuropathy, tarsal tunnel syndrome, that is a posterior tibial nerve, sciatica, that is sciatic nerve, and brachial neuralgia we have already mentioned. Sorry, here we have mentioned cervical radiculopathy, or here a separate name is given, cervical or brachial neuralgia, that is compression of a brachial plexus. So in upper limb, median nerve, ulnar nerve and radial nerve, these are the three common nerve. And as far as median nerve is concerned, carpal tunnel syndrome, anterior intraosseous syndrome and pronator teres syndrome are concerned with median nerve. Ulnar nerve at elbow, ulnar tunnel and Gaines tunnel canal syndrome. Radial tunnel and Wartenberg syndrome. These are in upper limb. In lower limb, sciatic nerve as well as piriformis syndrome. Peroneal nerve, that is tarsal tunnel, and lateral femoral cutaneous nerve, that is meralgia paresthetica. These are some of those. Today I'll be covering only carpal tunnel syndrome. So carpal tunnel syndrome is the most common entrapment of the median nerve at wrist. So it is the most common entrapment neuropathy. more common in female as compared to male. The ratio is almost, you can see here, 10:1. The onset of the age is between 40 to 60, more common in Caucasian. Median nerve is compressed in the carpal tunnel due to either a bony growth or because of a soft tissue proliferation or because of repeated trauma. This will be one of the pathophysiology. So carpal tunnel syndrome is the most common focal peripheral neuropathy, results from compression or we call entrapment of median nerve at the wrist. So entrapment takes place in this carpal tunnel, which is formed by transverse carpal ligament and bony structures which takes part in wrist joint. It can be classified into early stage, intermediate stage or advanced stage. Any condition that makes the area inside the carpal tunnel smaller increases the size of the tissue within the tunnel, either because of traumatic wrist injury, pregnancy, diabetes, hypothyroidism, or even arthritis. And this is because of increased force, posture, wrist alignment is disturbed, repetitive movements, temperature, vibration injury. There are some extraneous factors also like smoking, obesity, excessive consumption of caffeine, etc. are considered to be risk factors. So strong family history, probably they say there is some genetic predisposition. History of repetitive hand movements, particularly like laptop, person working on a what we call sewing machine, typing machine, etc. Obesity, rheumatoid arthritis, pregnancy, acromegaly, hypothyroidism, scleroderma, etc. can produce entrapment at wrist joint in carpal tunnel. One of the most common cause also is idiopathic. There can be edema or fibrosis of a tenosynovium, and mostly it is non-inflammatory. Also, carpal tunnel has a high coincidence with the thumb, that is metacarpal osteoarthrosis, and we have already mentioned it is because of repetitive motion, vibration injury, which will produce thickening of the carpal tunnel, transverse carpal ligament. And also we have mentioned some of the risk factors like pregnancy, diabetes, dialysis, RA, rheumatoid arthritis, obesity, hypothyroidism, acromegaly, amyloidosis, also mucopolysaccharidosis, etc. So there is a decrease in the size of the carpal tunnel either because of bony abnormality or maybe because of deposition of a soft tissue material like in hypothyroidism, diabetes, obesity, acromegaly, etc. So there may be increased content in the canal secondary due to wrist fractures or forearm fractures like Colles fracture or scaphoid fracture, dislocation, subluxation, or post-traumatic arthritis, and there is a formation of osteophytes, or there is an aberrant muscle, or there may be a tumor like neuroma, lipoma, ganglion, cyst, multiple myeloma, or there may be an arterial compression like persistent medial artery, or there is a hypertrophic synovium, or there may be hematoma, blood collections like in hemophilia or person who is on an anticoagulant therapy, or there may be traumatic injury. So these are lot number of causes which produces entrapment because it is a fixed space, and if anything is added in that fixed space it will produce entrapment or we call compression. And don't forget, still we are not able to find out the etiology, we label that as a idiopathy. So some of the neuropathic conditions like diabetes, alcohol, double crush syndromes, exposure to industrial solvents, inflammatory conditions like rheumatoid arthritis, gout, tenosynovitis, infections, etc. And some of the external injuries, external forces which produce injury like vibration injury or direct pressure because of repetitive movements. Alteration in fluid balance, this will be all indirectly in a pathophysiology, pregnancy, menopause, eclampsia, hypothyroidism, renal failure, long-term hemodialysis, Raynaud's disease, obesity, etc. Where because of little excess of fluid, it can produce local compression. A person who is doing a repetitive work and gets an injury, and there are good number of persons who are non-work related causes like diabetes, gout, hypothyroidism, rheumatoid arthritis, pregnancy, sprain or fracture at wrist. And we have already mentioned almost majority of all these causes. Most cases have no known causes, that is idiopathic. So a big list: aberrant anatomy, infections, inflammatory conditions, space occupying lesions, metabolic conditions, increased canal volume, etc. There are many different causes. And still, if we can't identify, we put them into an idiopathic group. Work related, repeated tasks like profession, tailor, sewing machines, then handling an objects on a convey or a belt, assembly line workers, gardeners, painters, homemakers, locksmiths, clerical worker, cashier, musicians, etc. These are all the people who does a repeated movement at the wrist joint, and they are more prone to get injury and hypertrophy of transverse carpal ligament. This already we mentioned. Smoking, advanced age, female, alcoholism, obesity, repetitive movements, etc. are the risk factors. Almost we have told you that 10:1 ratio, quite common, female more prone as compared to males. Increased incidence with diabetes, thyroid disorders like hypothyroidism. Peak age is between 40 to 60 years. Median nerve, three important compressions, neuropathy from distal to proximal, carpal tunnel, anterior interosseous syndrome and pronator syndromes, and you can have double crush. So you can get injury here or here or here. So carpal tunnel is here, anterior interossei injury, pronator syndromes, and you can get injury at the cervical neck, which will be first crush, and second crush can be at any one of these three areas. That's why it is called double crush syndrome. So double crush syndrome can be at the cervical root and carpal tunnel. So here you can have compression and you can have compression here. That is called double crush. So patient with carpal tunnel syndrome sometimes feels the pain in the forearm, elbow, upper arm, shoulder, chest and upper part of the back. Compression at one side decreases the threshold at another. You can have the pain at C6, radiculopathy and carpal tunnel coexist. This will be typical in case of double crush. Upper extremity examination begins at the neck. Beware, most common level for radiculopathy is C6 and similar carpal tunnel can create a confusion. So you can have those findings together, and then if we have got a compressive pathophysiology at C6 root, we call C6 radiculopathy, and we have got also compression at the carpal tunnel. This is described as double crush. This is a small tunnel. This is a bony portion and this is a ligament, carpal ligament. And if we get a compression in that particular tunnel, it is labeled as a carpal tunnel. And it can be fibroosseous compression or maybe because of edema or because of space occupying lesion, etc. In general, any entrapment can be fibroosseous, fibrotendinous, or abnormal band can produce compressions. The nerve is injured by chronic direct compression, angulation, or stretching forces. And that can be because of repetitive stress injury, inflammation, and then because of that, now the nerve transmission is reduced, and that results into symptoms and signs of carpal tunnel. So repetitive stress, prolonged compression, localized demyelination, and person will have a Wallerian degeneration, and that will affect the nerve conduction. So whenever the pressure exceeds 20 millimeter of mercury, the conduction will be reduced. More than 30 millimeter, it will inhibit the conduction. More than 80 millimeter, there will be cessation of blood flow, and these changes are transitory, short term, partly reversible. It is like tourniquet palsy. But once you get the demyelination, the changes will be irreversible. So because of compression, venous obstruction, it will produce ischemia, anoxia, neural edema, dilatation of small vessels, exacerbation of original compressions, continuation, it will become a vicious cycle, persistent edema, anoxia, hypoxia, replaced by fibrosis, impairment of the supply, deficiency of vital nutrients, functional impairment, and now then it will end up into permanent impairment of the function if not treated early. This is a typical pathophysiology which will occur in any entrapment neuropathy. Immediately there will be intraneural blood flow will try to restore as soon as you get decompression. There will be decreased intraneural edema after days and weeks, and remyelination and axonal regeneration may take place after months, but if not treated, irreversible damage. So mechanical or chemical irritations, vascular supply compromise, exoplasmic flow will be reduced, hypoxia, altered microvascular permeability, edema, and then it will end up into demyelination and intraneural fibrosis. That will be irreversible damage. This is called neuropraxia. When you start getting damage to the axon, it is called axonotomesis. And when neuron gets damaged, it is called neurotomesis. So compression, sheath is lost, demyelination takes place, and you will start getting degeneration of the axon. Also there will be effect on central cell body, and this will give rise to a permanent damage. Depending upon the severity of the damage, mild, moderate, and severe. In a mild, blood nerve barrier is damaged. In moderate, you will get edema and connective tissue thickening, and then you will start getting demyelination, which can be localized to diffuse, and then you will have axonal degeneration, which will be a severe variety. In a mild, symptom wise, intermittent paresthesia or aching pain. In moderate, persistent paresthesia, and now you will start getting weakness of the muscles. And in a late stage or we call severe variety, we'll start getting numbness and atrophy of the muscle, which will be of lower motor neuron type. In mild, you can get provocative taste positive. In moderate, you will have abnormal thresholds. And in a severe variety, you will have a 2-point discrimination will be affected. And that will be diagnostic of severe variety. So the area what is being involved, you can see here, it will be, we usually call 3.5 finger. So the area of the pain and numbness will be thumb with the 2 index and middle finger with half of ring finger also. And in that area, the person will complain of pain, numbness, paresthesia on the palmar aspect of the thumb, index and long finger, or we call middle finger. Plus, you will have also may get involvement of the motor fibers. Then you can have involvement of lumbricals, first and second lumbricals. And sensory we call as a 3.5 finger in the palmar region. So first and second lumbrical will be affected. Also, because of the involvement of the recurrent motor branch, you can have involvement of the thinner eminence where abductor pollicis longa, abductor pollicis brevis and opponens pollicis brevis pollicis will be affected. And you will have also loss of sensation in that palmar cutaneous nerve supply area. So this will be the common nerve which will be involved, components of medial nerve which will be involved. So you will have a motor fiber involving lumbricals and thinner eminence, and that will produce typical muscle involvement in the palm region. The earliest symptoms will be sensory symptoms in the form of a pain, numbness, tingling sensation, burning sensation, and they are worst at night, and person will become awake and he will flick his wrist many times. That's why it is also called as a flick sign or also called as a shake test, etc. And if there is a motor involvement, person can also complain of weakness and wasting of thinner eminence. That will be the common presentation. So irritative or inflammatory pain, paresthesia in the form of tingling or burning sensation, ablative numbness, dryness, thin and hairless skin. The ridge will be thickened, cracked nails. So nail will be, there will be ridges what will be seen, thickened nail, cracked nails, recurrent skill ulceration. These are all because of sensory findings. And because of the motor involvement, you will have a weakness and atrophy of thinner eminence. So commonest symptom, pain, tingling, numbness, or we call paresthesia in the distribution of medial nerve. And person will wake up in the night and he will shake his hands or flick his hand or flicking what we call, that's why it is called flick sign. Symptom improves with the flicking of their hand and wrist. You might have a temperature changes, and because of the involvement of the motor fibers, you will have a atrophy in the thinner eminence, and also you will have a weakness in the affected muscles. We already mentioned 3.5 finger area will be involved. You will have a sensory symptoms, that is numbness in the area where the supply of median nerve, pain, numbness, paresthesia in the palmar aspect of thumb, index, long finger and half of the finger, what we call as a ring finger. And if motor fibers are involved, clumsiness, weakness may be also seen. So numbness and pain are the most common symptoms, and you get a flick sign. We have already mentioned. So pain, sensory symptoms like hyperesthesia, paresthesia, muscle atrophy and weakness are in the late stage or severe compression. You might have autonomic changes, that is temperature changes, and person will find pain will be aggravated during driving, reading the paper, painting, etc. The typical movements. So motor changes will produce deformities, loss of movement, lagging. Sensory changes will be there. There will be loss of sensation in a area where medial nerve distribution is there. You will have autonomous changes like vasomotor changes, pilomotor changes, trophic changes, and you will be able to demonstrate Hoffman-Tinnel sign, Felon's maneuver, reverse Felon's maneuver, carpal compression, or we call Durkin signs. So you will have a Felon test positive, Tinnel test will be positive, or Tinnel sign will be positive. It is also described as Tinnel test, Tinnel signs, or Hoffman-Tinnel signs. And this is Felon test or Felon maneuver or reverse Felon maneuver. And there is a carpal compression called as a Durkin's. Will be showing you that. So this is typical Felon's. This is Tinnel test. You have to tap at the wrist over the carpal tunnel. The person gets tingling, numbness and pain, and this is the position of the wrist, and this is the another position of the wrist which will flex at the wrist, and that will stretch the nerve, producing compression of the nerve, and the symptoms will exaggerate. So diagnosis in motor examination: wasting and weakness of the median nerve innervated hand muscle. In general, it is called LOAF. L for lumbricoides, that is lumbrical muscles first and second. O for opponens pollicis. A for abductor pollicis brevis, and F for flexor pollicis brevis. So these muscles are affected, and that produces typical wasting and absence of those movements. So these are the different muscles which will be affected because they are supplied by median nerves. So you will have a weakness and clumsiness of the hand, thinner atrophy, very characteristic thinner atrophy. You can see here there is an atrophy. So that is a characteristic of a median nerve involvement. So in a mild variety, only sensory conduction is affected. So person will complain of numbness, tingling at night, no weakness. Diagnosis is usually by the medical history, and by and large we don't come across a physical finding. By and large they are not present. Only person has got symptoms, but even loss of sensation may not be present. In a moderate, sensory and motor are affected together. Sensory and motors are together. Patient will have a symptoms throughout the day, and provocative test will be positive. We'll be showing you those provocative tests. And in a severe variety, sensory and motor both are present, and EMG findings will be very characteristic, showing you the involvement of the muscle, and you will have a atrophy of the muscle and weakness of the muscle. Then it is in a severe group. So on inspection, if you get asymmetric or you get wasting, fasciculation, loss of sensation, and you get even loss of sensory symptoms like touch, pain, vibration, 2-point discrimination, and provocative test is positive, it will go straight forward into severe groups. So sensory examination will include modality test. So you test for pain, temperature, touch, pressure and vibration. Functional test is ability of the patient to perform fine apprehensive tasks with the discriminative level, and objective test will be Tinnel test, sweat test, skin resistant test, wrinkle test, and there are many other tests. So provocative test will be commonly Felon test, Tinnel test, and compression test. And some person also utilize tunicate test, but the chances of false positive will be higher in that group. So usually tunicate test is not commonly being utilized. Commonest test which is being utilized is Tinnel test and Felon's test. So we'll be showing you that. In a Felon's test, usually Felon maneuver is performed by flexing the wrist for 60 degree. This is 60 degree. This will increase the carpal tunnel pressure temporarily and produces the symptoms. If this test is positive, the patient will have a numbness and tingling in the hand and wrist. That is called Felon test positive, and it is in favor of carpal tunnel compression. This is typical Felon test, Felon maneuver. So wrist is undergoing a volar flexion for approximately 60 seconds, and if the symptoms are produced, we call that as Felon test positive. This is the way you have to flex at wrist. This is Felon maneuver or Felon test. Either you can do it at single or you can do it both together like this. Tinnel test is tapping at carpal tunnel. So percussion on the volar part of the wrist crease produces electric sensation distally to the finger, or you tap with the hammer or you tap with the finger. It is called Tinnel sign or Tinnel test, and if the person gets the typical electrical sensation, it will be more in favor of carpal tunnel. So this is one maneuver in Felon test or Felon maneuver. This is Tinnel test. There is something called the flick sign. So patient demonstrate flicking of the wrist and hand similar to shaking a thermometer, and that is given a name flick sign. Person will feel better. Then there is one test called as a hand elevation test. Symptoms are provoked by raising the hand above the head for 2 minutes. This is one test not commonly being performed. There is a square wrist sign. The ratio of anteroposterior dimension of the wrist to the mediolateral dimension, if you measure those two, and if it is more than 0.7, it is considered as a square wrist sign. Felon test we have already discussed. There is something called as a reverse Felon test, where you sustain the extension of the wrist, may also aggravate the symptom. It is ideally not a reliable test, but not commonly being done. The most common is Tinnel and Felon test. There is carpal compression test, where you compress at the carpal tunnel with the two thumb and maintain it for 30 seconds. This will be also, there is a second name called Durkan's test. Square wrist sign, you have to measure the ratio of wrist thickness, and if thickness to the width, if it is greater than 0.7, then it is in favor of carpal tunnel, but not commonly being utilized. That is called square wrist sign. Tunicate test is also not commonly being utilized because false positives are very common. Durkan sign is indirectly the carpal compression test. That is, you apply a direct pressure on the carpal tunnel with either a pressure of manometer or by thumb for minimum 30 seconds, and if it produces symptoms, it is considered as positive. And when you do a Weber's test for 2-point discrimination test, almost it will be positive in 1/3 of the cases. And you can also look for monofilament test for touch on the palmar side. That will be also positive in good number of cases. Particularly person will have a loss of touch sensation, vibration sensation and 2-point discrimination. So Durkin test is compressive test or carpal tunnel compression test. It is very sensitive, and just compressing with the thumb, a person gets tingling numbness and electric pain in the palmar part, it is considered as positive, and you have to maintain that compression for 30 seconds. And if a person gets pain and paresthesia in the distribution of the nerve, it is considered as positive test. Also, you can ask the person to draw the area in which he is getting a symptoms, and that is given a name, picture drawing. So if a person is able to self-administer hand diagram, so if you get 3.5 finger symptoms, it is again in favor of carpal tunnel. So numbness, night symptoms, thinner atrophy, positive Felon sign, positive Tinnel sign and positive Durkin signs. All these are characteristics of carpal tunnel diagnosis. And further you can do by monofilament testing, you can do by nerve conduction study and also EMG. And also you can go for static or moving 2-point discrimination. That will be very sensitive regarding sensory symptoms. So night pain is almost 96% sensitivity. Durkin test is 89% sensitivity. Monofilament testing 83% sensitivity. Hand diagram confirmation can be almost 76%, much better than even Tinnel sign. Tinnel sign is only 71%. You can see the sensitivity. Night symptoms itself is a very sensitive predictor. So abnormal hand diagram, abnormal sensory testing, monofilament neutral or a monofilament testing at rest, and positive compression test and night pains, that is what we call a Durkin test, and night pains is very common, and they will be almost 90% sensitivity. EMG does not increase the diagnostic value. So, but EMG can help you to confirm the motor system involvement or motor fiber involvement. So there are other tests also done very commonly, like Benedict's hand sign, Osher test, carpal tunnel sign, Felon's test, reverse Felon test, nail sign, bottle test, pronator test, etc. There are different maneuver to confirm the compression of median nerve. There is one test called as a OK test or OK sign. This will happen in a person if he has got an anterior intraosseous nerve injury. And this is also given a name, Benedictine sign, Benedictine sign or OK sign, and that confirms anterior intraosseous nerve injury. Or it is also given a name, pinch grip test, anterior intraosseous nerve test, or also called as a Clon Nevin test or OK sign, and that is going to confirm your anterior intraosseous injury. So OK sign is used to check the paralysis of anterior intraosseous nerve due to entrapment or compression injury, and good number of time even during decompression procedure that nerve can be damaged. So this is a typical OK sign, which is a test for anterior intraosseous nerve injury. Typical pinch attitude associated with the anterior intraosseous nerve injury. You can see this is normal, this is abnormal. This is normal, this is abnormal. And these muscles will be affected. So You can check that. This is, you can see this is normal, this is abnormal. So this is abnormal, this is abnormal. You can see this is normal, this is abnormal. This should be the way. But if a person is not able to do this movement, we do suspect anterior interossei nerve injury. So Benedictine sign cannot do the OK sign, and that confirms anterior interossei nerve injury. So this is normal, this is abnormal. So this side anterior interossei nerve injury. Name given: pinch grip test, anterior interossei nerve test, Benedictine sign or OK sign or kilo Nevin sign, etc. These are the different. So by and large, clinical evaluation is very, very important. Good history, good clinical examination, followed by nerve conduction study and EMG. Already we have mentioned that EMG is not predictive but can be helpful to confirm the motor fiber involvement. So EMG, nerve conduction study, will be helpful to find out the severity of involvement. You can also utilize CT or MRI. Sweat test not very commonly being done, and by and large the clinical history and good clinical examination is more useful than other. So now conduction study, EMG, particularly EMG depending upon which part is being involved, right from cervical region till tip should be done. That is, now conduction study should be done. EMG and now conduction study is very important. Almost in 20% of the people it may be negative, particularly in a mild variety. So now conduction study for sensory part will be very useful, and EMG is usually before surgery. EMG you can do, which will give you a different waves, P wave, fibrillation wave, polyphasic wave, etc., showing you the severity of injury. And once you do the procedure of decompression, you repeat the EMG, and if it shows improvement, it will give you an idea regarding the improvement of decompressions. Very rarely you require a nerve biopsy or a skin biopsy, not commonly being done. MRI will be helpful to find out any fat material, lipoma, ganglion, etc. So radiography are not routinely utilized, but in a suspected patient, you can find out those to decide regarding a decompression part. So MRI, now ultrasound is also one of the simple technique which can help you to find out any compressions in carpal tunnel. So ultrasound in a non-invasive, and then that can give you a very good idea regarding non-compressive, and it is also utilized. You take the help of ultrasound guided hydrocortisone injections as a part of treatment in case of a carpal tunnel. 2-point discrimination is very, very helpful to find out the severe nerve compression. So 2-point discrimination will be affected in a person with severe decompression. Even this we call as a monofilament test will be very helpful also to find out light touch involvement. Vibration sensation you can utilize. So indirectly sensory system examination becomes very useful. Plain X-ray, MRI and CT will be more useful than plain X-ray. And to find out some of the etiology like diabetes, HbA1c, glucose, TSH, then CPK, CRP, B12 level, RA test, ANA test, anti-CCP, etc. to rule out collagen disorders. Those will be helpful. At the same time, you have to keep it in mind the differential diagnosis like tendinitis, tenosynovitis, diabetic neuropathy, as well as compression of median nerve at elbow can produce similar symptoms, and also sometimes radiculopathy. So myelopathy, brachial plexopathy, radiculopathy will be very close differential diagnosis. You will have to find out that. So you will have to differentiate from those groups. So cervical radiculopathy, brachial plexopathy, thoracic outlet syndrome, pronator syndrome, peripheral neuropathy, etc. will be a differential diagnosis. This is one figure which tells you median nerve, radial, ulnar nerve, and anterior intraossei nerve, where we get OK sign positive. Here, this will be typical ulnar claw hand you will get, and in median you will have a finger flexion, sensory involvement in 3.5 finger. Here in a radial it will be on the dorsal surface, or we call extensor surface, while in ulnar it will be 1.5 finger involvement. This will be very peculiar. This is typical what we call as presentation of a claw hand, which will be ulnar claw hand, and this is a median claw hand. In an ulnar claw hand, you will have these two fingers being affected, while in a ulnar claw hand, or this will be ulnar claw hand, and in a median, the two digits, that is ring finger and terminal finger, flexion will be normal, while here the flexion will be affected. So extending finger at the wrist, distal median nerve involved, and the signs will be median claw hand, OK gesture with digit 1 and 3 flex, 1 and 3, 1, 2 and 3 digit will be flex. Well, this is called as a pop blessing. So peace sign ulnar, radial nerve thumbs up, median nerve power of the people, and OK sign anterior intraossei nerve. This is the sum of the signs. Diagnosis you are confirming by clinical. Carpal tunnel compression we call as a Durkin sign, Tinnel sign, Fennel sign, and by now conduction study. There are some conservative treatment like weight loss may be beneficial, local ice application may give a partial relief, and rest will be beneficial. Decrease in repetitive movements, night splint like this will be helpful, and then you can have hand ergonomics, and if there is no improvement, then person might require a carpal tunnel release, or we call decompression. So general measure, wrist splint, oral medications like analgesic, anti-inflammatory, local hydrocortisone, ultrasound therapy, etc. And then late stage, if no improvement, then only surgery. This neutral wrist splint helps a lot. And second procedure, that is local hydrocortisone, will be another thing. So conservative treatment, activity modification, wrist splint, corticosteroid injection, ultrasound therapy, nerve gliding, some of the medications, oral steroids or NSAID, etc. can be utilized. And then we call as a carpal tunnel release either by open or endoscopic surgery. Open is always better than endoscopic because in endoscopy there is always a chance of partial release. So depending upon you can decide. Non-operative we already mentioned, avoid the activity that aggravates the symptoms, NSAID, splint and local steroid injections. And we have already told you operative is open or endoscopic. Surgery will be indicated if failure of a non-operative procedures, if all this fails, then or if there is a weakness and atrophy of the abductor pollicis brevis, objective sensory changes demonstrated by nerve conduction study, electrophysiological evidence of thinner muscle denervation, etc. will be a good indication for surgery. Steroid injection is one of the procedure which can be done. Failure to improve after injection is a poor prognostic factor. And in this case also even surgery will be less effective if person does not improve with steroid injections. So chances of improvement will be relatively less if there is no improvement. Surgical procedure is done removing the offending structure, release or decompression or exploration. If there is a SOL like neuroma, you can go for neuroma excision, nerve repair, nerve resection, nerve grafting, or nerve or muscle transfer, etc. These are all different modified procedures. So while doing a surgery, always you have to see that this motor nerve should not be damaged. So it is important to cut the transverse carpal ligament far ulnar to avoid recurrent motor branch of the median nerve. That should be taken care. Recurrent motor branch of median nerve. This is a recurrent branch. So you should not put an incision here. Put incision towards the ulnar side. And best is indication of surgery, failure of non-operative, weakness atrophy, EMG positive, or nerve conduction study showing you the damage to the sensory pathway. So in those conditions, you should go for. And there are two procedures, open or endoscopic. So open carpal tunnel release, usually pain will be relieved within 3 to 4 months. Dynamic symptoms resolves rapidly. Release of carpal tunnel and dependent contractures at the same time may make the condition worse. Advantage of endoscopy is a small incision and decreases the pillar pain and early return to the work. Disadvantage is incomplete release and may injure the nerve, artery or tendon because it is through a small opening. Repetition of a carpal tunnel release is not commonly being done and it does not give a good results. By and large in this release outcome 25% of the people will have a complete relief, 50% will have some relief and 25% will have no relief. Sometime in an open you will require a larger incision, may be required in some of the person, not in all. Repeated carpal tunnel and failure of release, carpal tunnel release will be because of incomplete release, incorrect diagnosis, double cross or triple cross, peripheral neuropathy, space occupying lesion or iatrogenic median nerve injury. This will be some of the causes. Post surgically you will have to go for regular exercises. Complications, by and large a person who is not treated early will have irreversible damage as far as sensory and motor system is concerned. and person who undergoes early investigations and early decompression, or we call early release of carpal tunnel, they will get good prognosis. So indicator of good prognosis is person who was having night symptoms, complete release, relief of symptoms with steroid injections, and there is a small incision. This will be a good predictor. So I end my lecture here. If you like this lecture, please don't forget to press button like, subscribe, and you can share with your friends. Thank you all for taking out time. I know that your time is valuable, and I appreciate that you have spent some of the time with me. See you in next lecture, and your valuable suggestions are welcome. And good number of slides I've gathered from YouTube, which is a very good slide series by Dr. Abraham.